Recording started.
Okay, so as I started to say, I'm very pleased to have Amy Yorke here. She's a professor at the University of Michigan, and her specialty area is working with balance and fall deficits, particularly with people with cancer. She just completed her PhD studies and on functional deficits and chronic problems, and I'd like to turn the microphone over to Amy right now, and Amy hopefully will be able to advance the slide. So here you go, Amy. Thank you for being here.
Thanks, Jackie. So again, thank you for this opportunity to speak about the physical therapy management of individuals with central nervous system cancer. So if you do have a question, you want to raise your hand. I'm going to try to pay attention to it, but I can't guarantee that I'll be perfect at it. So if I don't see your question, it's just my oversight, and we can have question answer at the end. So although the incidence of central nervous system tumors is really relatively low when compared to other cancers, CNS tumors can have a significant impact on an individual's life. And over time, treatment for central nervous system cancers have improved and survival has increased, leaving adult survivors of CNS cancer with neurological deficits, functional and psychosocial sequelae, leading to decreased ability to be independent in their daily lives. So physical therapists really have a unique set of knowledge and skills to assist adult CNS cancer survivors maximize their functional capabilities.
Amy, you seem to have lost the microphone. Can you click on it again here? I'm going to click off.
Thanks, Jackie. I did, because I clicked to move the slide, so thanks for noticing that. So our objectives here is that you could recognize the incidence and prevalence of CNS cancers, differentiate between primary and metastatic CNS cancers, describe common impairments, activity limitations, and participation restrictions found in adults with CNS cancers, select examination tools and outcome measures, and develop an evidence-based plan of care in adults with CNS cancers. So the presentation focuses on cancer of the CNS. So just as a quick review, the central nervous system consists of the brain and spinal cord that are both protected by bone, with the brain being protected by the cranium and the spinal cord being protected by the spinal column. The brain and spinal cord consist of gray and white matter. Gray matter consists of the nerve cell bodies, dendrites, and axons, while the white matter consists of axons covered in myelin. So the incidence is the number of newly diagnosed cases of a disease, and the median age for diagnosis of all CNS cancers is 57 years. When only considering primary malignant and non-malignant CNS tumors, so it does not include metastases, you would anticipate 20.6 new cases per 100,000, with non-malignant making up the majority of new diagnoses, and females being diagnosed more frequently than males. Prevalence is the total number of cases of a disease existing in a population, and in 2010, primary brain and CNS tumors were 221.8 per 100,000 people living with a diagnosis, which equates to approximately 680,000 Americans. So this is United States data. Living with primary central nervous system tumor, with the greatest number of adults living with non-malignant tumors than those with malignant tumors. And that just makes sense that a malignant tumor would eventually take somebody's life, so the thought that not people are living with more non-malignant tumors just makes sense. So the median age of death secondary to CNS cancers is 64 years, and if you remember, the median age of diagnosis was 57 years. And in 2012, there was an estimated 13,700 deaths secondary to primary CNS tumors in the central nervous system. So as a review, cancers in the CNS can be primary, that is originating from the CNS structures themselves, or metastatic. Gliomas are the largest group of primary brain tumors in adults. Glial cells are the support cells of the CNS and consist of astrocytes, oligodendrocytes, and microglia. The second most common primary brain tumor in adults is a meningioma. A meningioma is a slow-growing tumor which arises from the arachnoid cells. Most meningiomas are considered to be benign, though some may be malignant. In adults, metastases make up the majority of brain tumors, approximately 70%. The most common cancers that metastasize to the brain include the lung, breast, and melanoma. Once a patient is diagnosed with brain metastasis, prognosis is generally less than a year, and the treatment is palliative. In the spinal cord, extradural metastases are most common, while the most common type of primary spinal cord tumors are meningiomas and neurofibromas. The World Health Organization classification system is the most commonly used system to classify a brain tumor. Earlier attempts to develop a TNM-based classification for brain tumors were dropped since tumor size, or the T, is less relevant than tumor histology and location. Nodal status, or the N, does not apply because the brain and spinal cord have no lymphatics. And the metastatic spread, or M, rarely applies because most patients with CNS neoplasms do not live long enough to develop a metastatic disease. Grades are determined at biopsy based on the histological presentation of the tumor, including cellularity, number of atypical cells, mitosis, microvascular proliferation, and the amount of necrosis. Prognosis is inversely related to age and the tumor grade, meaning the older you are or the higher grade you have, the worse the prognosis. Your condition at the time of diagnosis is directly related to prognosis, meaning the less impairments a person has when diagnosed, the better the prognosis. The grading system ranges from 1 to 4, with grade 1 meaning slow growing, possibility of a cure after surgical resection, grade 2 meaning infiltrating, slow growing, but often recurs or progresses to a higher tumor grade with a median survival of 5 to 10 years. Grade 3 is considered malignancy, and it has infiltrative capacity and is treated aggressively. Grade 4 is rapid disease progression, it's active, and the tumor is actually necrosis prone, has the worst prognosis, and is treated very aggressively. So specifically talking about specific tumors, a glioblastoma multiforme is considered a grade 4, and it's the most common primary brain tumor in adults, and it occurs in the 50s and 60s with a median survival of 1 year. A meningioma is the second most common tumor. It's a slow-growing, most commonly benign tumor, and the cure is really surgical resection, and again, most people are diagnosed in their 50s and 60s. An acoustic neuroma, or vestibular schwannoma, is a tumor that grows around the Schwann cells that myelinate cranial nerve 8, or the vestibular cochlear nerve. A cure is surgical resection, including stereotactic radiosurgery, and a person after that will end up with a loss of vestibular and/or cochlear function. So just a quick review of metastatic brain tumors. Again, they account for more than 60% of all brain tumors. And 20 to 40% of patients with cancer develop brain tumor. 50% with lung cancer, 15 to 20% of those with breast cancer, and 10% of those with melanoma. And typically the prognosis is less than a year and treatment is palliative. Again, let's review spinal tumors. Extradural metastases are the most common. Symptoms that a patient experiences are from compression, so as the tumor grows, it'll compress around the structures. Cancer from lung, breast, prostate, kidneys, thyroid, myeloma, or lymphoma are most commonly then spread to the spinal area. And again, primarily the location is, the majority is thoracic at 70%, followed by lumbosacral, followed by cervical. So prior to a diagnosis being made, a patient may present with a variety of symptoms, and I think this is important to consider, recognizing that the majority of brain tumors do come from metastases. So you may have been serving a patient that had been treated for lung cancer or breast cancer or melanoma, but now is presenting with some other signs and symptoms that may cause you to reflect to see, well, has it potentially metastasized? So headaches are actually present in approximately 65% of the cases. Nausea and vomiting due to increase in intracranial pressure is about 10% of the cases. In 30% of the cases, patients may present with decrease in visual acuity, diplopia, and visual field deficits in association with papilledema, which is swelling of the optic nerve. Seizures are found in 15 to 50% of adults. Changes in cognitive functioning can occur in approximately 75% of patients with brain metastasis. Spinal metastasis present as back pain in 95% of cases, and it is usually dull pain and is worse at night. So I want you to take a moment and just reflect and think about a time in your clinical practice when you may have worked with a patient who presented with signs and symptoms of central nervous system cancer, however was referred to physical therapy prior to the diagnosis being made. I can remember early in my career meeting a woman in her 40s who was sent to the outpatient clinic I was working at. She had significant back pain, which that was the reason she was sent to physical therapy, which was actually increasing over her course of therapy, which was approximately 4 weeks. After being sent back to her primary care physician, further diagnostic testing found spinal metastasis that had originated from her undiagnosed breast cancer. And I can so vividly remember her crying in physical therapy because her back hurt so bad. I do not know what ended up happening to her, but it was that experience that made me understand how important it is to listen to your patients and to consider all potential causes of back pain beyond the musculoskeletal reasons, and to consider that patients may have undiagnosed cancer that has already metastasis. So once a tumor is identified, the cancer in the central nervous system is managed typically through surgery, radiation, or chemotherapy, as well as any combination of the above three. Also, other medications utilized to providing care include the use of corticosteroids and anticonvulsants. Corticosteroids are used to reduce the inflammation and edema, but also for pain control and palliation. Anticonvulsants such as Dilantin are used to control or eradicate seizures. There are also some emerging therapies when it comes to CNS cancers, including stem cell-based therapies and gene therapies. So during or after medical and surgical treatment of adults with CNS tumors, rehabilitation services needs to be aware of potential concerns. Complications can occur after surgery, including but not limited to infections, CSF leaks, and focal neural deficits. Seizures have been reported in 20 to 40% of brain tumors depending on the location and type. Side effects from radiation, chemotherapy, corticosteroids, and anticonvulsants will need to be managed. Adults receiving radiation can develop an encephalopathy. Being on corticosteroids can induce a myopathy and/or a steroid-induced psychosis. If a patient is on Dilantin, they can develop a toxicity where the patient will present with increased lethargy, confusion, nystagmus, low blood pressure, slurred speech, ataxic gait, and decreased balance. So if you're working with a patient who has had a brain tumor removed and is progressing and is on Dilantin, but suddenly seems to be regressing, report your findings to the team so a blood draw can be determined to see if the level of Dilantin is appropriate in the blood. Adults with CNS cancers are at increased risk of DVT and pulmonary embolism. Fatigue is also a common patient report. Consider that if radiation therapy could be scheduled in the afternoon and physical therapy or rehab in the morning. Changes in cognition due to either the location of the cancer and/or treatments need to be considered. It is also important that other comorbidities continue to be managed and be considered in the context with physical therapy plan of care, including but not limited to bone health or osteopenia, immunosuppression, neutropenia, thrombocytopenia, anemia, and fever. When working with an adult with CNS cancers, considerations for what phase of care as well as the setting will guide you in your decision-making processes. Each describe 4 phases of care. Phase 1 is preventative and consists of education and early intervention. Restorative care as phase 2 is when it is anticipated the person will return to independence. Phase 3 is considered supportive and goals are directed toward maintaining and/or preventing further decline in ADLs while facing progressive impairment. And phase 4 is considered palliative, where comfort and preservation of independence are the goals. The setting you are seeing the patient in will also influence your decision making. Adults with CNS cancers may receive physical therapy services in a variety of settings, each of which has its own unique circumstances. The International Classification of Functioning Disability and Health described by the World Health Organization provides a framework for considering how health and disability are measured. The health condition or disease or disorder would be considered cancer in the CNS for this presentation. Body functions are the physiological functions of body systems, including psychological functions. Body structures are anatomical parts of the body, such as organs, limbs, and their components. Impairments are problems in body function or structure, such as a significant deviation or loss. Activity is the execution of a task or action by an individual. Activity limitations are those difficulties an individual may have in executing activities. Participation is involvement in a life situation. Participation restrictions are problems an individual may experience in involvement in life situations. Environmental factors make up the physical, social, and attitudinal environment in which people live and conduct their lives. A recent study completed in Australia categorized patient-reported disability in adults with primary brain tumors. What they discovered is this core set were similar to stroke and traumatic brain injury. In another study, cognitive and psychosocial problems were more frequently reported by brain tumor survivors than physical disability. So for a moment, I just want you to consider how might an adult with central nervous system cancer present. And how would the presentation of an adult with a tumor in the brain present differently than a tumor in the spinal cord injury? And what other neurological diagnoses may be present as similar to someone with CNS cancer? What do you already know about the examination and management of adults with central nervous system disorders? And consider, how would the management of an adult with central nervous system cancer be different than someone with a stroke or spinal cord injury? So based on our experience, thinking about how adults with CNS cancer present may be different. For example, I can think of adults where the CNS cancer had metastasized versus adults where the tumor was primary. Depending on the location of the tumor in the brain, I may expect to see more of hemiparesis or ataxia, particularly if the tumor was impacting the cerebellum. If the person had an acoustic neuroma, I would anticipate seeing vestibular cochlear deficits. If the tumor was in the spinal cord injury, I would anticipate seeing paraparesis or quadriparesis depending on the location of the tumor. And again, remember, most tumors in the spinal region are in the thoracic region. A person who's had a stroke or traumatic brain injury can look similar to someone with a brain tumor, just as if a person with a spinal cord injury can look similar to a person with cancer of the spinal cord injury. Considerations of why the physical therapy management might differ for a person with a stroke or traumatic brain injury, spinal cord injury versus CNS cancer could be to the progressive functional decline that we commonly see in CNS cancer, prognosis, the psychological adjustment to a constantly changing disability, side effects of treatment, depression, and medical fragility. According to the American Physical Therapy Guide to Physical Therapist Practice, utilizing patient-client care management model will assist in leading to optimal outcomes. The examination consists of taking a history, systems review, and tests and measures. Evaluation is where the physical therapist makes clinical judgment based on data gathered during the examination. The evaluation is when potential problems may be identified that require consultation with or referral to another provider. Diagnosis is where the physical therapist organizes the results of the examination findings into clusters, syndromes, or categories. CNS cancers would commonly fall under the neuromuscular practice pattern in the Guide to Physical Therapist Practice. Prognosis, including plan of care, determines the level of anticipated improvement through intervention and the amount of time required for that level. Intervention is the skilled care the physical therapist provides, while the outcomes specifically look at the impact physical therapy has on the impairments, functional limitations, disability, risk reduction prevention, health and wellness, societal resources, and patient-client satisfaction. The presentation will continue using this and the ICF framework when we look at the management of an adult with central nervous system cancer. As we start to delve into specific examination and intervention for adults with CNS cancer, I wanted to make a point to not forget the fundamental examination tools and interventional strategies we implement in adults with movement dysfunction, no matter what the cause. I've provided a listing here of items traditionally thought of as part of the physical therapy examination or intervention. This presentation will not be covering these items. So a person with cancer in the central nervous system will present with decreased muscle strength. Besides utilization of the traditional manual muscle test, you can also consider utilizing other functional-based measurements, including something like 5 times sit to stand, 30-second chair stand, and grip strength. As far as when it comes to intervention for decreased muscle strength, I think it's important to consider that the United States Department of Health and Human Services has physical activity guidelines that are for just the general public. And what's important to recognize is that when they put these out, they also started to talk about patients that have chronic conditions. And what they really encourage people to do is to be as active as possible and to avoid inactivity. The National Comprehensive Cancer Network has encouraged patients with cancer and cancer survivors to try to incorporate exercise or activity into their day, looking at least 30 minutes a day, 5 times a week. We recognize there's lots of barriers to that, and we're going to talk about that a little bit later in the presentation. Another impairment commonly experienced by patients with cancer is fatigue. Examination tools to examine fatigue include something called the Brief Fatigue Inventory, the Global Fatigue Index, and the Fatigue Severity Scale. Actually, one of the best intervention techniques for fatigue is a regular exercise program, but again, that's a really hard sell to people that are feeling very tired. As well as energy conservation techniques, which include pacing, delegation of tasks, prioritizing, scheduling, taking short naps, and avoiding multitasking. Another impairment commonly seen in patients with CNS cancers is pain. And in order to accurately assess pain, you could use something like the visual analog scale, the numeric rating scale, such as tell me what your pain is on a scale from 0 to 10, or something more comprehensive, such as the West Haven Yale multidimensional pain inventory. For intervention, utilizing things such as guided imagery, biofeedback, deep breathing, and education about positioning and posture and body mechanics could also be effective. Cognitive changes may occur directly due to the location of the tumor or as a complication of surgery and/or treatments. Utilizing tests such as Alert and Orion ×3 and Mini Mental Status Exam might not be sensitive enough to determine an impairment. The Montreal Cognitive Assessment and Trail Making Test Part A and Part B may actually do a better job in picking up deficits. If you identify deficits, consider a referral to a neuropsychologist and/or a speech language pathologist. For physical therapy, if you know a person has decreased cognitive functioning, make sure your instructions are easy to understand, provide education in multiple formats, and also to caregivers. And you may also want to consider avoiding dual tasking, such as walking while talking. A recent study investigated the implementation of cognitive rehabilitation early, that is within 1 week of surgery, in patients with central nervous system tumors. In this randomized controlled trial, where the study group received cognitive rehab in addition to other therapies, including medical management and physical therapy, while the control group simply received standardized care, medical management, and physical therapy with no cognitive therapy. The study group statistically improved pre-cognitive therapy to post-cognitive therapy 4 weeks later in all outcome measures. So again, I want you to consider if the patients that you're potentially seeing for physical therapy with brain tumors, do they consistently receive a speech language pathology evaluation, or is somebody evaluating their cognitive status? Because this study does show that patients with deficits due to brain tumor can demonstrate changes. Another impairment commonly seen is vision, and that can be impacted directly or indirectly. Making sure a patient has full visual fields and checking visual acuity using a Snellen eye chart, or even gross visual acuity by checking near vision, which could be like a wristwatch, or far vision like a clock on the wall. Impaired low contrast vision is related to increased risk of falls in older adults and abnormal postural stability in breast cancer survivors. So when it comes to physical therapy, one of the things that we don't necessarily directly treat vision, but what we can make sure is do education regarding the fact that we do use our vision to help hold our balance. So if your vision is impaired, you're going to have a harder time using your vision. So making sure that they think about removing clutter, so if they don't see something, that they don't trip over it, and maybe using bright tape on steps. And then also considering a referral to a neuro-ophthalmologist or maybe an occupational therapist that is a low vision specialist. When examining vestibular function, utilization of the Dizziness Handicap Inventory is a measure of perceived handicap. The oculomotor examination provides a glimpse into how well the person's inner ear is working and includes testing for nystagmus, both spontaneous and gaze holding, smooth pursuit, saccades, VOR slow, and VOR fast and static and dynamic visual acuity. Gaze stability exercises have been demonstrated to decrease subjective complaints of imbalance and improve postural stability in patients who have undergone acoustic neuroma removal. So with a patient with an acoustic neuroma removal, you would anticipate vestibular dysfunction. So one of the exercises that I just talked about was ×1 or ×2 gaze stability. So here's a slide. What you would actually have the patient do is look at a stable object and turn the head side to side approximately 30 degrees. You'd complete this exercise for 1 to 2 minutes, and you could also repeat it moving the head up and down. And the exercise should be completed at least 3 times a day. ×2 gaze stability exercises are the same activity except for the patient's head is moving. The card or the object being moved would be moved in the opposite direction that the head is moving. So if the head was moved to the right, the card would be made to the left. But always the patient is to maintain focus on the object. And again, both of these exercises would need to be done 1 to 2 minutes because it takes the brain that long in order for adaptation changes to be made. So both of these exercises consider using in particular with patients that have had acoustic neuroma removal. So if we're kind of moving away from impairments and kind of now talking more about activity limitations. If we look at this kind of activity limitation of balance, there's several different examination tools you could use, including the activity-specific balance confidence scale and the Falls efficacy scales, which are both just self-report tools looking at the confidence or self-efficacy regarding their ability to keep themselves upright. The Berg and Tinetti, the clinical test for sensory interaction on balance, are performance-based tests where you actually have a patient actually do some tasks. And then the mini BEST test. So the BEST test was developed by Faye Horak. And if you look at that figure that I have, she developed this test in a way to look at balance of recognizing there's several systems that go into holding balance. So if we examine balance looking at the system approach, we can also intervene. So the BEST test, it was the larger test, which takes about 40 to 45 minutes. And what they did is did some analysis on each of those items and thought we can still capture the same information and use the mini BEST test. What I like about using this test is that, again, it looks at examination and intervention of balance from a real systems approach. So looking at things like biomechanical constraints. So does the person have adequate ankle range of motion? Looking at things such as stability limits and verticality. Is the person able to hold their balance? Anticipatory postural adjustment. So if a person goes from sit to stand, can they make the correct adjustments in order to keep themselves upright? Postural responses. How does a person respond to an external perturbation? Sensory organization. Knowing that we rely on our vision, vestibular, and sense of touch to hold our balance. How well does the person weight those different sensory systems, and how well do they keep themselves upright in changing sensory conditions? And last but certainly not least is stability and gait. How does the person do with a dual task? How does the person do while walking and turning their head? So considering with activity limitation, looking at examination of function, the FIM and FAM, functional independence measure, functional assessment measures, are commonly used tools to determine level of caregiver burden. In the United States, the functional independence measure is a tool used consistently in inpatient rehab. The Karnofsky Performance Scale Index, scale of 0 to 100%, allows patients to be classified as to their functional impairment. This can be used to compare effectiveness of different therapies and to assess the prognosis in individual patients. The lower the Karnofsky score, the worse the survival for most serious illnesses, which again goes toward prognosis, that we know if a person has more severe impairments, more severe activity limitations, the worse prognosis it is. The Barthel Index, score of 0 to 100, is a measure of functional disability and has been found to be very easy to use because it can be self-report or performance. It's reliable, sensitive to change, and has a prognostic value when utilized in patients with brain tumors. So now let's move toward intervention of functional training. Really, our intent is to prevent the effects of prolonged immobility. And there really needs to be an emphasis on early mobilization, which means in intensive care after that tumor is removed, that we want patients to be up and we want them moving. And higher functional improvements is a significant predictor of longer survival. So if we now kind of look at examination of gait, and then we'll go to, keep moving toward intervention. The gait speed is something that is very easy to measure, and we know that we can categorize patients based on their gait speed, meaning if they're walking less than 0.4 meters per second, they're going to be a limited ambulator or a really limited household ambulator. 0.4 to 0.6 is this limited community. 0.6 to 1.0, again, it's limited community. Greater than 1.0, typically we tend to think of these people as more community ambulators. Easy to measure, lots of data regarding gait speed. Dynamic Gait Index and functional gait assessments are tools that I would consider using with a higher functioning patient, particularly someone with an acoustic neuroma. Timed Up and Go, which has a patient go from sit to stand, walk 3 meters, turn around and come back. The manual task for that actually has them carry a glass of water, and the cognitive task while you're doing the Timed Up and Go actually has them count backwards by 3s. You could also use the 2, 4, 6 minute walk test. And then also something called the Massachusetts General Hospital Functional Ambulation Classification actually just simply categorizes patients according to basic motor skills necessary for ambulation. The scale runs from 1 to 6, 1 being non-functional to 6 being independent in all surfaces. So now kind of moving toward participation restrictions, looking at examination of quality of life. The Eastern Cooperative Oncology Group performance status, the perceived impact of problem profile, and the Cancer Rehabilitation Evaluation System is really a way to try to gather information kind of beyond our impairment and activity-based measurements of really looking at how is the person's quality of life. And I believe that that's a really kind of important component to consider when we're looking at a person with central nervous system cancer. So continuing with our ICS model, remember there were personal environmental factors that can impact our patient. So if you wanted to assess depression, there's the Center for Epidemiological Studies Depression, or Depression Anxiety Stress Scale. And I also think, particularly with this diagnosis of central nervous system cancer, I think it's important that we consider the role of the caregiver. And the quality of life of caregivers in those with glioblastoma have been found to be very low. So there's a couple different tools that you could use to kind of measure caregiver burden. So there's the Zaret Burden Interview Caregiver Perception of Burden and the Caregiver Strain Index. So when we kind of consider this concept of a caregiver, it's really important to consider what does a caregiver need. And a caregiver needs information, and this is highest immediately following a diagnosis. And they need clear information about diagnosis and treatment, and it needs to be presented in several times in varying formats, and they really need to know what to expect in the future. A caregiver needs communication, and you really want to help give that caregiver, you want to empower them so they know how to effectively communicate with everybody on the caregiving team. And again, you want to give them strategies, and you also want to recognize that their emotional needs are also being taken care of. And it's not necessarily that we're the primary caregiver or healthcare provider that does that, but recognizing it and getting them the help that they need. So again, when we think about prognosis, again, you need to consider tumor grade, grade 1 versus grade 4, the type of tumor, and things that we know that are more negative is the greater tumor involvement. So the greater, the larger the tumor is, the more negative prognosis. If a person has poor functional status to start with, it has a more negative prognosis. If they're female, if a person's divorced, if they're unable to work, if they receive chemotherapy, and like I stated before, the tumor grade. So some recent literature looked at comparison of outcomes. So these were just 3 studies summarized by Kirschblom that demonstrated that adults with brain tumors make functional gains similar to those adults who have had a traumatic brain injury or stroke. What was also interesting was that adults with brain tumors also demonstrated decreased length of stay as compared to those with stroke or traumatic brain injury. And the authors hypothesized this may be due to the approach of discharge planning, improved psychosocial support, and decreased behavioral problems that are seen with patients with brain tumors. So I'm sorry, that study was from 2001, but from a more recent study, patients with brain tumors improved on the FIMS, the Functional Independence Measure, sitting standing balance scores, the Hauser Index, and the Massachusetts General Hospital Ambulation Classification. And so the group to the right, the group to the left is brain tumor patients, and the group to the right is a group that had sustained a stroke. So in the same study, if you divided those in the group that had a glioblastoma multiforme, meningioma, and stroke, the meningioma improved their FIM discharge at ADL and demonstrated significant gains in those with ADL's mobility and cognition. So what I find most interesting about this information is actually the potential bias that all of us may bring when making discharge recommendations. Because what we found is there was no difference between glioblastoma and meningioma and stroke when it came to outcomes for sitting balance, standing balance, the Hauser Index, and then the Massachusetts General Hospital Functional Ambulation Classification. So, for example, if you're working in acute care with an adult who has a glioblastoma multiforme, you may consider that the person being discharged home with hospice might be the best choice for the patient who has less than a year to live, since if you were given the choice to go to rehab versus going home, you would choose home. But evidence demonstrates that patients with brain tumors improve at rehabilitation despite the potential for a poor prognosis. And I'm simply making this point to allow you to self-assess and recognize any biases that you might have when it comes to working with adults with cancer in the CNS. So earlier we talked about just barriers to exercise. And we do know that oncologists are hesitant to prescribe exercise, and cancer survivors have reported a lack of interest and practicality, fatigue, decreased physical function, and social isolation. And really, we feel like there's really a lack of guidelines for patients with cancer-related fatigue, and 2, just simply a lack of referrals for physical therapy when a person is diagnosed with cancer. So some strategies to try to help manage these barriers is really looking to promote physical therapy to cancer survivors and to the oncology healthcare team. And so when our biases come forth, like why would a person want to go to inpatient rehab after they've had a glioblastoma multiforme removed? Because evidence does show that they will make gains, and they'll make gains similar to those with a stroke. And again, we need to place higher priority on addressing the barriers to exercise, recognizing the fact that exercises that are supervised, that are individually tailored, and that the concepts of the patient starts to feel the benefits of exercise so that they are continually motivated to exercise are some things that we really need to manage. So I quickly want to go through a couple case studies. The first one is a 65-year-old male admitted to acute care oncological floor secondary to onset of bilateral lower extremity weakness, and the MRI demonstrated metastasis to the spinal cord at several levels with spinal cord compression noted at T10. And so my question to you is, what would you anticipate examining on the first visit? And maybe what outcome measures would you utilize? So the examination results, of course, was decreased muscle strength, sensory deficits, and pain. The person demonstrated several different activity limitations, really regarding mobility, including gait. He was a husband, a father, grandfather. He was retired, but he loved to golf. And some environmental personal things was that he was depressed, but he had a very supportive spouse, and his home was arranged on the first level. So if I was to diagnose him using the guide to PT practice, I'd say impaired motor function and sensory integrity associated with disorders of the spinal cord acquired in adulthood. Things that were kind of played a role in his prognosis is it was metastasis, so that's more negative. Supportive spouse, he was very healthy, really premorbidly. And he was admitted with the inability to ambulate. So again, his functional status was significantly impaired. So the plan of care written was for physical therapy daily, 5 days a week, and will include ambulation with a front-wheeled walker, wheelchair mobility, working on transfers, strengthening, and education. Well, after the third visit, the patient reported increased fatigue and absolutely refused to ambulate. And I had a conversation with his wife, and what she told me was that he had really started to give up because the patient realized he would never walk again after assessing his progress with physical therapy. So this guy wanted to walk, and so by golly, I walked him. And walking 10 feet with a rolling walker, even with max assist, was walking to me. However, he realized that he was probably never going to walk again. So again, I kind of ask these questions: what does walking mean to our patients, and what does walking mean to a physical therapist? Because I think we could potentially have very different views. Second case study is a 46-year-old female that began to notice decreased hearing in her left ear, and she went and saw an ear, nose, and throat physician who ordered an MRI with contrast, and it was revealed that she had an acoustic neuroma. She was referred to neurosurgery and neuro-otolaryngology, and surgery was scheduled about 8 months after the original diagnosis, because commonly with acoustic neuromas, they're very slow growing, so they'll watch them. And once they start getting, the tumor starts getting larger, that's when they'll go in and do surgery. Unfortunately, during surgery, the patient sustained a small cerebellar infarct. So with this case, I try to kind of outline 3 different settings. So in acute care, she demonstrated spontaneous nystagmus. She required minimal moderate assistance for bed mobility and transfers. And she required moderate assistance with the front-wheeled walker for ambulation. She was very ataxic. Treatment really focused on caregiver education and mobility, and she was discharged to home with home PT and a wheelchair. While she was in home care, she received both PT and OT services. The Berg Balance Scale, she scored a 20 out of 56. She began ambulating with a front-wheeled walker at household distances with minimal assistance, and she was unable to stand without upper extremity support with her eyes open and her eyes closed. She continued to require assistance for bathing and dressing, and treatment focused on balance, progressive mobility, and gaze stability exercises. In the outpatient setting, she completed the dizziness handicap inventory, which again is self-perception of handicap due to dizziness. She started ambulating with a straight cane. The dynamic gait index scale is there, and treatment focused on balance, gait, gaze stability, exercise, progressing toward independence in the home exercise program, and really working toward her goal of returning to driving and riding a bike and actually returning to work. So she returned to work full-time as a faculty 5 months after her surgery, and she currently ambulates without an assisted device. She drives. She's able to ride a 2-wheeled bike. She does have spontaneous nystagmus, which could have been due to her acoustic neuroma, but if it was due to her acoustic neuroma, that would be gone now. So now it's believed to be more due to the stroke that she sustained. So she's under the care of a neuro-ophthalmologist, and she wears prism eyeglasses. And she had also developed sleep apnea as a result of the stroke that she sustained during surgery. So in review, we covered central nervous system cancers can come from the brain or spinal cord injury. It can be benign or malignant. It can be primary or metastatic. And I think you always need to consider special considerations, recognizing that patients with cancer bring things to the table that are different than somebody who maybe has a stroke or traumatic brain injury, spinal cord injury. The ICF model is a great way to kind of think about how you select your outcome measures. We also have 4 phases of care, and depending on the setting that you're working may depend on the choices of examination and intervention that you use. And again, I use that patient-client care management model. So I've included some resources here for you that if you're not familiar with many of the outcome measures, these are some of the links that I use. And I can tell you by far I use the Rehab Measures database. It's a great website for outcome measures. Gives you a great review as well as the tools available to actually access the tool. So here's my list of references. So I thank you for your attention, and I will now shut off my mic and open the mic back up to Jackie, and I'll take any of your questions.
Amy, thank you for your presentation. That was very good. I particularly liked the evidence-based practice. I liked the case studies, and then I enjoyed having you present things about caregivers who are a lot of times overlooked. I'd like to open up the program right now for any questions, and you can either type them into the chat room here in the left middle. So I'll put in a little thing that says type here, or you can take over the mic to ask a question. So I'm going to turn off my microphone, and if anybody wants to pick up the microphone and ask a question, or if you want to type in a question in the chat box, you can do that. So I'm turning off my mic, and somebody else can pick it up. Okay, this is Jackie again. And there's a question from Maureen that their group joined late and they want to know if the slides will be available. Yes, what happens is that this system allows us to record it, and what you'll see probably by tomorrow is that we'll put up a link on the WCPT website. So if you want to go to that website, you can access the recording. Hopefully it'll be there tomorrow because I have to send it to people that are in the WCPT. Any other questions? I see Oren's typing, so we'll wait just a minute. Or maybe Oren's not typing. Amy, I actually have here's the website to the WCPT. Thank you, Oren. You're invaluable with your information. Amy, I do have a question, and we talked about this a little bit earlier. So many of these people are put on steroids, and I haven't seen any research for what type of improvements that you can make with muscle loss related to steroids. So I'm going to give you the microphone back if you could comment on that.
Yeah, I have not seen anything either, you know, in the literature. And I think if I was to look, I'd start to look toward the, because there's been a lot of work recently on the steroid-induced myopathy, particularly in patients with intensive care units. And I don't know if it's not necessarily studied in patients with CNS cancer because they don't survive long enough to get a good idea about it. But I think that goes kind of promoting that we should be using more standardized outcome measures. So whether that be grip strength that you can monitor over time, and if you did monitor that over time, could you track, would there be a level of potential grip strength that would kind of be a tipping point to say, okay, now it's starting to become so weak that we need to consider doing something. So I'm not an expert in steroid-induced myopathy, but I do think that our involvement, and then our involvement in really using standardized measures, can potentially impact the medical care and or the eventual functional outcome of a patient.
You know, and this is Jackie again. Another thing that Amy and I had talked about in another session was where do people get information? Where do physical therapists get information on treating central nervous system cancer? So could somebody address that in their area of practice as to how they learn about taking care of these patients? And I'll turn the mic off. We'll also watch the chat line. Okay, nobody's brave enough to talk on the microphone. All right, I'm happy to do it. Oren does say that through the chat line, from his experience, people who get more than 40 milligrams of prednisone will have a very difficult time regaining muscle strength. So there's a good study for your PhD, Oren. There's also some very kind comments here from Christopher. You did a thorough work, Amy, and he's saying thanks. And Maureen says, thank you so much for a wonderful presentation. And Oren says he's done 4 weeks ago. Okay, well, I have to say congratulations on your earning your PhD, and maybe this is an area we can study in the future. There's so little information about how to work with people with central nervous system cancers. We have actually a certificate program for post-professional PTs, so people who are practicing PTs on oncology rehabilitation, and we cover the central nervous system in one of our classes, and then we develop some surveys or screening tools for patients. But even in our certificate program, it's just 1 week that we spend on it, so there isn't even a lot in our area. I will see if there's any other questions, but as I already discussed with Maureen, this will be up on the WCPT website that Oren put up the address for on the website. So those of you that came late, or if people that you know want to watch this or review it, it'll be available probably by tomorrow. I also want to again thank Amy Yorke for such a wonderful presentation, and we will be giving her the International Scholar Award, which we award to people who are invited to our presentations here. And so, Amy, you're getting a round of applause from a few of the people in the audience here. If there are no further questions, oh wait, I see a question. Donna Seaver, I think. Let me turn over the microphone to you. This is Jackie again. I guess some people can't get on the, okay, Donna's no question. Just so people know, the next presentation will probably be in February. We still are deciding on a speaker, and we will be using a different setup that will hopefully be more user-friendly, so there will be more networking and interactions. It's through WebEx, and we'll get you links for that during our next presentation. And if anybody who's not a member of our developing subgroup, if you want to send me your email address, we can include you on our emails. About they come out about 4 times a year, so you won't have a lot of things in your mailbox. So again, Amy, thank you very much, and if there's no further questions, I will close out the program today. Thank you kindly for your attendance.